Yeah. Questions so far? Oh, this is just bigger so you can read it. All right, I'm gonna skip through that. So the one thing I've recommended in your practice is some sort of pause to let people, so when you terminate resuscitation, I often involve everybody there, including family members. Anything else, anybody have any ideas, anything else you want to do? And then whoever makes that determination, the highest medical provider on scene, typically the paramedic, make that, we'll say what time it is and we'll stop. And some people, like hospitals, have protocols where they'll say like, Chad was a life on this earth and we have to think about Chad as a human being and blah, blah, blah. I tend not to do that. For me, I find it like, it feels scripted and weird to say some sort of speech. I just leave it at, for me, I say, let's take, everyone take a 10-minute pause, or 10-second pause, and I just let the room be silent for about 10 seconds, make sure the monitors are off or anything, and just let people sort of reset. It gives you time to reflect on, this sucks, somebody's died, there's family in the room. And I think sometimes, at least in my ER world, it gives you a chance for staff to reset as well, to be able to go on to the next case and do the next thing, or do the next call. So what's difficult about death in the field, right? It's sudden, unexpected. We have suicides, homicides, accidents. We don't know the survivors well, and the reaction to survivors are varied versus our gradual, this isn't the person who's like on hospice, chronic disease. We do see some of this stuff, but often we're in this unexpected category, which I think makes things difficult. And grief is also very variable, right? The way people respond is different. So grief is an emotional and physical response to death. There's cultural and demographically diverse. You'll see all sorts of things in different cultures. Sometimes it can be abnormal, pathologic. People say usually it's 6 to 12 months, but usually after several weeks things start to improve. But again, all this is not created equal and depends on what actually happened and what people's grief response is. So these are sort of the stages of grief. They don't necessarily, we like to think these happening in order, but they don't, right? You could have denial, anger, bargaining, it should have been me, depression, acceptance, withdrawal. You can have these maladaptive responses, blaming others, guilt, anger, and violence. The great news is, this is rare. It doesn't happen very often, but we do see it from time to time. Who's predisposed to grief? Sudden unexpected death, that's what we're dealing with in EMS often, right? Suicides or homicides, pediatrics, kind of makes sense. Family dysfunction. A good thing is we, at least in the pre-hospital setting, we don't care about our family dysfunction, right? Like you see all sorts of people out there with screwed up lives and stuff going on. Psychiatric conditions and people with survivors of drugs and alcohol use. So some responses, there's adaptive grief. This we love, easy to deal with, open to ensuring events, able to meet their fears, open flow of emotions, sharing without blame and resentment. Sometimes I feel most guilty around some of these people because I've had these things where I'm like, God, like these people have been, this woman just lost her husband of like 70 years and she's making me feel better about it. Like it's just amazing how like some people approach things. So this is pretty easy to deal with. Action-oriented. I think back when my father-in-law, who was on hospice and died, and this was sort of me, like, I was in medical school at the time, and I was trying to like help out and sort of, just kind of like do all the organizational stuff. And it was really this action-oriented grief. I was trying to organize activity, buffer from the pain. I was like, I was working as the organizer, supporting other survivors, but I didn't really deal with my grief for that for a couple of days. So you do see this as well. Calm usually represents a degree of denial. Sometimes they need help initiating grief response. Sometimes you may need to encourage viewing the body and spend a little extra time. This viewing of the body, I often, if people are doing a resuscitation or if somebody dies, remember like suicides, homicides, obviously it's a crime scene, so that's an exception, they can't really be there. But sometimes like I'll ask patients, would you like to be by their side? Do you want to come in? If they say no, that's okay. They gotta make their decision for themselves. Guilt or blaming, we see this a lot. I shouldn't have let him leave. Balanced reality of support. We had a dead guy up in Walpole yesterday who the housemate was like, oh my God, he told me he didn't feel well and he was gonna take a walk in the yard at 9:30 last night to get some air. I should have kept an eye on him. Like that's an example of that, right? Balanced reality of support, and and you don't want to reinforce his guilt and be like, yeah, like you should have checked checked out for that guy. I usually, I just said, what, like, who are you to know? He just wanted to get some care. Like, he didn't do anything wrong at all. That's to try to support them. Demonstrated behavior. This is that verbal striking out. I had an experience when I was a resident where we were it was bad trauma. Guy lost his wife, and basically, we'll talk a little bit about this. When you get down and talk to somebody, I often will get down to their eye level. So if they're in a chair, I'll get down and talk like this. And this person took my hand and started punching themselves, like slapping themselves in the face with my fist. Didn't hurt me, but I just kind of let them do it. Know what to do. I just let them do what they need to do. But you'll see, you can see people acting out, punching a wall, maybe stuff like that. And usually it's a lot of times it's an avenue of release for them. Violent behavior. This is what we have to watch out for. Classic, right? Males, 15 to 30 years old, attempt to regain control. This is where you don't counter a threat. Don't, your safety is the most important. Extricate yourself in that situation or use law enforcement to help you. And they need some privacy, but generally don't leave them alone, but kind of like it's not our problem at that point if it's dangerous. Impaired survivors, intoxicating psychiatric illness, personality disorders, they may have an exaggerated, uncontrolled response. So you may have to this may be a situation, if they're the only person there, you'd be like, we gotta get out of here. This person is not able to be controlled in any fashion. They can't handle this and it's just not safe for anybody. And guilt, it's common, right? Sometimes appropriate. You don't want blaming. Blaming leads to a prolonged grief response, and you want to try to relieve it as much as possible during death notification. So a lot of survivors, they really want questions answered. I try to answer medically as best I can. They often want to be with the deceased, which I think is healthy for a lot of people. And I was asking if they want to be present. And generally, the way we run our codes, if you can find a spot for them to be where they're sort of out of the way, either at the foot or the head or wherever you think, or even a chair just in the room, I find it's often helpful if they're appropriate. All right, so how do we tell bad news? All right, so this is the mnemonic. This is Sherry Hogwood from the University of North Carolina. I put this together, all the way back in 2005. So the first thing you want to do is gather, right? You want to make sure families of survivors are there. And I usually often ask if there's a family member upstairs to try to get everyone, it's a kind of a pain in the ass to tell people twice what's going on. So I try to make sure that everybody's in the room at once. Sometimes you need your team with you. If you're really good at this, bring the new EMT with. If you're going into the kitchen, they don't want to be at the patient's side, and bring the new EMT with you. Bring somebody with you that that can kind of learn from this as well, because I think this is one of the things you see somebody do it, they're pretty good. A private, quiet space, we don't really have that. You want to be prompt, right? It's good if there's a family minister, family friends, a neighbor, just somebody with them to kind of assist them. We don't know. Again, we don't have the luxury of this, but sometimes if there's people there, that's helpful. You want to identify yourself in your role, kind of figure out who's present, how are you related, who are you with. Shake hands, sit or stand at eye level. I'm a huge fan of getting at that eye level, even getting below their level a little bit. And I often say, what do you know that's happened going on so far? And they may say, I know he's dead. I know she's dead. Or, I don't know. I just saw them collapse and, I haven't been in the room.